welcome to this webinar on obesity and COVID-19. This webinar is kindly supported by Novo Nordisk. My name is Dr. Grace Lee. I'm a general practitioner and I also work for the Goodfellow unit. Tonight I have the pleasure of introducing Dr. Rinki Murphy. She is an associate professor for the University of Auckland and a diabetologist at Auckland DHB and Middlemore. All right, so we'll start now and I'll let Rinki take the lead.
Thank you very much, Grace, and welcome to you all. Tēnā koutou, kia ora, namaste, and good evening. I'm delighted to have the opportunity to talk with you tonight about obesity and COVID-19, and I will be very keen to take any questions you may have. So the outline of tonight's session is to start with the impact of COVID-19 on people with obesity. I'd like to share our experiences of going virtual with shared medical appointments for weight management and share a few cases that highlight weight management using low energy diets, medications, as well as bariatric surgery before a summary. So firstly, my disclosure. And coming to the COVID-19 confirmed cases, as of Friday last week, there were 12,043,000 cases worldwide, with just over 500,000 deaths. And by country, luckily in New Zealand, our confirmed cases have been very low comparative to our population, and very few deaths thanks to public health measures. But beyond its actual confirmed cases and deaths, it certainly left an impact on the way we practice medicine. One of the key high-risk groups to develop severe illness from COVID-19 has been the group of people with severe obesity. And given our prevalence of obesity in New Zealand, we were certainly very concerned about what impact COVID-19 would have on our population. And we know that from various other conditions that people who are older, who have any severe chronic condition, particularly lung disease, chronic kidney disease, heart conditions, diabetes, have all had higher risk of severe illness from infective conditions, including COVID-19. So people of non-European and minority ethnic backgrounds are also overrepresented in severe illness. So when we look at COVID-19, the actual virus, severe acute respiratory syndrome, coronavirus 2, and the development of COVID-19, the risk of contracting this virus is not different by BMI of either overweight or obesity. And we'd expect that a high proportion of people who contract COVID-19 will have higher BMI, concordant with the population prevalence of obesity and overweight. However, when we look at the statistics for people who have higher risk of complications and adverse outcomes, people with obesity, like other chronic conditions, are overrepresented. So when we look at American data associated with COVID-19 hospitalizations, you can see that the proportion of people with obesity is almost a half. And when we look at the population obesity rates in adults in the United States, obesity is prevalent in 40% of the adult population. So it's only a small amount of overrepresentation by COVID-19 cases. However, when we look in China, where the overall prevalence of obesity is lower, we still see that in the group who have critical ICU admissions, that the mean BMI is higher in the group who have ICU admissions compared to the general group. And when you look at the people who are survivors versus non-survivors, the non-survivors were more likely to have higher BMI. In terms of the French data, again, we saw that the proportion of patients requiring mechanical ventilation also increased, concordant with mean BMI being in the higher categories. So there are a number of potential pathways linking the severity of COVID-19 and obesity, including the confounding factors of lower socioeconomic status, health-seeking behavior, diet, activity, and ethnicity, but also obesity in itself having its impacts on lung hypoventilation, increased cardiorenal stress with hypertension and ambient type 2 diabetes risk, also culminating in lower cardiorespiratory reserve, such that there is increase in ability to not cope with the demands that are linked with COVID-19 and respiratory compromise. There is an immune hyperreactivity phenomenon as well that can be mediated or exacerbated by excess adiposity and potential for viral shedding and viral load with hypoventilation, and culminating in increased severity of the COVID-19 infection once it's been contracted. However, more studies are needed to better define the interaction between COVID-19 and obesity, and we need to know that, remember that these observational studies are incomplete and that the urgent timeline of data extraction, small sample sizes, and often not peer-reviewed publications means that it is premature to draw conclusions on the definitive causal link with obesity and severity of COVID-19 outcomes. The other impacts of COVID-19 has been in everyday life and the treatment of people with obesity. Many of our elective surgeries were curtailed during the lockdown period, and this is still to be caught up. Obviously, weight loss programs were also impacted, and I'll be sharing some of our experiences at the Auckland Diabetes Centre with you in regards to that. During the lockdown period, this increased sedentary behaviour and immobility, and self-isolation also could have impacted the quality of the diet and the ability to access fresh fruit and vegetables. While some people were able to increase their home cooking, there had been some reliance on processed foods during this time. And this self-isolation did have a psychological toll, and you will be more aware of that than I in terms of general practice visits in relation to this, and being able to access this during the lockdown period was severely restricted. Going virtual with shared medical appointments for weight management was one of the issues we dealt with during the lockdown period. And I'd like to share with you a relatively new system of utilising shared medical appointments for weight management in our setting. So shared medical appointments for weight management can be defined as individual medical consultations that are run sequentially in groups of participating patients. And obviously everyone in the group listens to each other's consultation. And so there are some issues around privacy and confidentiality that we have our participants sign a confidentiality statement, and we take the lead from the individual patients as to what they'd like to disclose with the group. It can also be referred to as programmed shared medical appointments if there is a discrete educational component that's provided in a semi-structured form. In our case, we decided to go with a shared medical appointment system for a low-energy diet-based weight management program that was modelled on direct study, which concerns meal replacements to achieve significant weight loss. So whilst we'd been running the face-to-face sessions in the Auckland Diabetes Centre, during the lockdown period, we had to transform our follow-ups into an online format and offer patients the appointments via Zoom or via telephone to link in. And we thought this was very important given that we'd formulated a group that needed to continue its momentum during this isolating period. So the way we designed the shared medical appointments and how we selected our patients for it was really, firstly, we set up a Auckland Diabetes Centre volunteer database and invited the volunteers on the database to discuss the idea of a shared medical appointment, the timing of it during the day, how frequent we should be running it, the content and the support that they would have liked. And one of the things that came out of it was that some people preferred the single-sex groups, other people had a heterogeneity in the timings that they were wanting and frequency, but we tried to go with the majority for this and scheduled this to run as logistics would allow. The patients were selected by the shared medical appointment team that was included a dietitian, a nurse and a doctor, and our clinic patients were approached from the Auckland Diabetes Centre. So approximately 1 in 3 patients who I approached were interested in the low energy diet-based weight management support and wanted or were happy for this to be in a group-based delivery in the shared medical appointment format. Our dietitian contacted all the referred patients and planned the sessions. So the resources that were developed were largely dietitian-led, and we had a doctor, a nurse, and health psychologist. Myself and my colleague, Doctor, only had a small role in the initial visit and in the 8-week visit, and all the fortnightly visits in the interim were dietitian, nurse, and health psychologist involved sessions. We thought about doing a narrated PowerPoint by experts with evidence and key points for the participants to view at any time. However, this wasn't made available at the time of our first 2 sessions, and we're currently developing those at the moment. We did have a participant booklet and low energy diet samples with fortnightly groups that were virtual only during the lockdown period. And following the lockdown period, with the success of the virtual groups, we decided that subsequent cohorts would have only the virtual option for follow-up. So we called our program a shared medical appointment for low energy diet weight management, and we ran it in 3 cohorts, the first beginning in October last year, the second session in February, and one that I started last week. And during the lockdown, the February session converted to virtual, and we collapsed all of the 3 cohorts as follow-ups thereafter. So they were all combined, had the opportunity to have graduates from the earlier cohorts in the latter ones. We had myself as the doctor on Zoom for the last cohort 3 when I had an upper respiratory tract illness, and the dietitian and nurse-led program will continue until 8 weeks time from now. So this is very preliminary data showing that in the first cohort we had a mean weight loss of 7.5 kilos and a concurrent mean drop in HbA1c of 12 millimoles per mole with less medications. So very promising results, but the key will be in the long-term follow-up, which is why we would like to continue offering the follow-ups on a monthly basis throughout. There's several pros and cons for conducting virtual program shared medical appointments, the pros being lower non-attendance, accessibility, less time taken for patients to attend, and the ability to ask questions privately, even in the group shared medical appointment setting, and no transport requirements. However, the downsides are the lack of anthropometric data, particularly weight and blood pressure, although people did do their own self-weighing and some had home blood pressure monitors. There was increased administrative support required for scheduling staff and also for organising the sessions and inviting them to the sessions. Communication cues were somewhat less over Zoom, and the follow-up prescriptions were more time-consuming. We'll have more data on our shared medical appointment experience once we're underway with longer-term follow-up, and there will be a natural attrition rate with not all people attending as time goes on. But I'd now like to switch to...
Rinki, just a question and also some commentary. Now, shared medical appointments are something in primary care which are a little bit of an unknown, or at least to me, and I'd be interested in your views with regards to any comments of how you think we might be able to adapt this in primary care. And I'd also really be interested in the audience out there listening tonight if they would like to feedback through any commentary from their end with regards to shared medical appointments. Is this something that we're offering in primary care, and if not, what are the barriers? So please feed through some commentary, and perhaps we'll have time to go over it towards the end. So any comments first, Rinki?
Well, I appreciate the help that Janine Bycroft provided to us with shared medical appointments, and also Pinnacle PHO had a system for shared medical appointments that they'd been using. And so I am aware of some primary care practices who are more familiar with this than ourselves, and we decided to adopt it in our situation with the resources that we've had, which is quite distinct. I suspect if you have got a practice nurse with an interest in weight management, that they would be the best person to potentially take the lead on this. If you were lucky enough to have a dietitian, that would be ideal. And potentially there's models out there from other PHOs that have the system working. So I can certainly nominate a couple if people are interested.
Thank you. I'll let you carry on.
Thanks, Grace. I'm going to move on to a case-based approach for weight management, and these are some successes or some people who are representative of a few of the approaches that I've tried. Firstly, I'd like to introduce you to Dan. His name's been altered, but his pictures will be real as he's consented to them. He was 56 when I first met him. He'd had type 2 diabetes for 6 years. HbA1c was 58, BMI 39. He'd just had his second coronary stent placed in 2015, and he'd had a history of atrial arrhythmias, hypertension, hyperlipidemia, ex-smoker, and had 2 or 3 standard drinks 3 days a week. He was managed on metformin, atorvastatin, omeprazole, aspirin, sotalol, gliclazide, and lantus insulin. He was really keen and motivated for weight loss, and had tried several times with Weight Watchers program with transient success. And when I mentioned the direct study around that time when it first broke, he was very keen to try the VLCD or very low calorie diet with his wife Judy, who was also at the appointment. Dan and Judy went on to have a medical supervised Optifast very low calorie diet, Optifast being one of the products that's available in pharmacies, comes in a sachet of a milkshake, a bar or a soup, approximately 200 calories in each of the meal replacements. And they went on a very strict diet of 3 meal replacements per day and a list of non-starchy vegetables and foods that they could have on top and some protein. But every week they had very good weight loss of about a 1.5 kilograms, and these are some pictures they put together and blogged about their journey. So a year down the track, they were both approximately 27 and 20 kilos lighter from their start weight, and a year later even transitioning on to maintenance foods or real foods, which was a very different exit diet to the entry diet. Dan continued to lose weight down to 90 kilograms. So both of the couple were foodies, self-confessed, and hence I was very surprised at what they were able to put together in their list of free foods whilst on the Optifast diet, and they blogged about their food journey and continued on their exit diet with these very low carbohydrate and low calorie food items that they were able to sustain as a couple. So a year later, Dan actually was in remission from type 2 diabetes, his HbA1c dropping to 36, and in fact his metformin and gliclazide and lantus insulin had all been stopped. His BMI reduced from 39 to 29, and his blood pressure had normalized on low dose or on no very low dose antihypertensive, and his lipids had also normalized. And the reason for performing this study really was published in 2018, or end of December 2017, shortly around the time that I met Dan, around remission of diabetes with this program. And this was actually primary care led in Scotland and in the UK, where practices were randomly assigned to providing this weight management intervention or control, and what they were offering was this total diet replacement of 800 kilocalories per day using a formula diet. and this was led by a nurse or a dietitian in the practice who had a specific training around how to deliver the very low calorie diet and what to say at each of the phone calls and face-to-face appointments. And at 12 months, and subsequently they published their study results at 2 years, that half of the participants had achieved remission to non-diabetes status and were off their diabetes drugs, much like comparable to bariatric surgery in without surgery in a third of the cases. And the people who achieved remission had dramatic weight loss of 15 kilos or more.
Rinki, just a question or two around the direct trial and OptiFast. With the direct trial, we know that, well firstly, if we were to try and sort of replicate this in the primary care space that we have now, is there any place or space that you know of in terms of how do we upskill ourselves in terms of education, so therefore we can educate and guide our patients?
Yes, so there is a protocol that comes together with the OptiFast and information for healthcare providers, and that is available on the OptiFast website. And similar things apply to using Cambridge weight loss products as well, but the OptiFast one is actually freely available to download. I have found in my experience that some people do not like the taste of OptiFast, and so it's worth making sure that people trial it before committing to purchasing one of the big boxes. And in that case, there are some free foods that one can try and assimilate your own version of lentil soup, or some calorically low but nutritional food substitutes, which is a bit more challenging to prepare. And we don't have a New Zealand adapted direct program such that their resources aren't directly applicable to the way we live and practice in New Zealand. So we would need to modify it to our population. It is an area of research, and we do need some people to champion this in their practices and teach us all about their experiences.
Thank you. And with regards to the OptiFast formulation, do people get constipated on it?
Yes, that's a good point. They do get constipated, and Beni fibre is a good one to use for constipation. Also, using a couple of tablespoons of olive oil with salads is something to help with keeping the gallstones at bay and keeping the gallbladder contracting. Initially, you can get quite some headaches, some tiredness, and general kind of feeling of irritability and hunger. And that tends to pass after 3 days in the ketosis phase. But it is hard work, and it doesn't suit everybody.
I really like how your patient integrated, although he was on OptiFast, yet he integrated a whole lot of different approaches. So he made his intentions very visible. He did a blog, so made himself accountable for it, brought in his partner, so had a colleague alongside him that actually shared the journey with him. So it sounds, although OptiFast was the driving factor, he incorporated a lot of the other things that we like to discuss in our weight loss management plan in terms of making it stick. So that's really nice to see. We do have a few more questions come up about OptiFast. And the first one is there any evidence in an increase of panic attacks when on OptiFast?
Yeah, so I don't think the OptiFast itself promotes that, but I think if people are anxious, then just having a change to general routine can aggravate any pre-existing issues, but I don't think that's a recognised side effect.
And the other one was, how long can you be on OptiFast for?
Yeah, so in the intensive phase, it's generally only for 12 weeks, and we do use that for short or longer periods based on some finite outcomes, such as a targeted weight loss for elective surgery, or a shorter period for intermittent use. So following on from Dan and Judy's journey, they did use OptiFast from time to time. They went on a European trip, for example, came back and had gained weight, so they redid their own OptiFast program. They knew what intensive phase was like. They knew what the restrictions with that. So this was going to be a long-term journey to using Optifast to deal with weight regain and relapse.
You talked about remission in the direct trial with diabetes, which sounds really exciting. I'm also aware that with diabetes, as time goes on, there's cumulative damage. Is there a point in time where remission is no longer achievable with a very low-calorie diet?
Yes, and we can see that with bariatric surgery because of the more significant impacts on caloric restriction. And we see about 80 to 90% depending on which types of patients are chosen. So key factors such as requiring insulin, long duration of diabetes, and reserved C-peptide, although that one is not as well documented, could be some clues as to when remission is no longer possible with very or lowish C-peptide, long diabetes duration and insulin use. So we do have data for 6 years or less without insulin. We don't really know about the rest.
Thank you.
Great questions, appreciate those. So I'd now like to introduce Ray as the second case. He's 35 years old, and in fact, his main concern was this discoloration of the anterior part of his neck that had developed in the last year, despite him trying to include lifestyle changes and improve his diabetes, as he thought this condition, which is acanthosis nigricans, was related to diabetes. Before he saw me, he had already improved his HbA1c of 78 with the addition of vildagliptin and dapagliflozin that he was self-funding, an SGLT2 inhibitor, and despite having type 2 diabetes was still on oral agents. His BMI was 33 and he had been previously referred for bariatric surgery but had declined. He wasn't keen on a very low calorie diet program. He had dyslipidemia, controlled blood pressure, and had vitamin B12 deficiency and likely secondary to metformin, which he had replaced. So for diabetes, he was on vildagliptin, dapagliflozin, gliclazide, and metformin. He was also taking 2 lipid-lowering drugs and cilazapril. So I discussed the role of medications. At that stage, we only had exenatide registered for use in New Zealand, a GLP-1 receptor agonist, a GLP-1 being the key hormone that's released in response to food from the gut, and it amplifies insulin secretion. So it improves diabetes, and at higher doses, particularly the liraglutide form, is able to act centrally to lower appetite and hence is registered for weight loss. Exenatide's only registered for diabetes control, but also has some modest weight loss associated with this treatment. I discussed phentermine, which is available, an unfunded medication again at approximately $100 per month, which acts as a sympathomimetic and therefore reduces hunger, improves satiety. And topiramate, which is registered for migraine prevention and also epilepsy prevention, also produces modest weight loss in combination with low-dose phentermine. So,
sorry, just a quick question around these medications, of which I think at least the top one and the bottom one will be a little bit new for many of us practicing in general practice. For myself, topiramate is something that, as you rightly pointed out, I'm very familiar with in the migraine and epilepsy space. Because these medications are licensed for particular things, I was wondering how you counsel and discuss these sorts of medications that you're using in a different way for weight loss in order to bring across a medication that you're using in a slightly different way for the patient that it's registered for. And not only that, but for us out there who are a little bit conservative like myself in terms of practicing, how do you keep ourselves safe in terms of prescribing medication, which is essentially, from what I can see, off license?
Yeah, so exenatide is certainly indicated for diabetes control, and given Ray had an HbA1c of 58 and desired weight loss, that would be a substitution or an improvement towards his goal of an HbA1c closer to 50 without weight gain. So by replacing gliclazide, he would have modest weight loss without an improvement in HbA1c. topiramate, it is, as you say, licensed for use in New Zealand for migraine and epilepsy prevention. And in Ray's case, I discussed with him the papers showing that low-dose topiramate and phentermine were licensed in the US for weight management indications, and he was agreeable to using this for that reason. I did not ask him to sign a formal consent, but some people do if they're using off-label indications. But I summarised our discussion in the clinic letter quite clearly, provided him with the data sheets for both of those medications and the information on its use for weight management. So communication is really key, and making sure that patients understand what the risk benefits are. So
one have to pay for the topiramate?
The topiramate is funded, and he did actually mention that he had some headaches. They weren't migrainous, and he only mentioned them after I talked to him about what topiramate was currently indicated for. And he actually did have a good result with topiramate and phentermine. This is the data on phentermine use continuously versus intermittently. And here the weight loss is in pounds, but it's approximately 10 kilos, 2.2 pounds in a kilo. So 10 kilos weight loss at 24 and 36 weeks. And there's also data showing that when you combine phentermine with topiramate as a low dose combination, that in 3 different studies, that at the higher doses of 15 milligrams phentermine daily, or even 7.5 combined with 46 milligrams of topiramate or 92 milligrams of topiramate, you can get up to 10% weight loss. And hence I approximate the combination phentermine topiramate, which has a trade name in the US as Quisimia, with our topiramate separately to phentermine. There is exclusions for people who are taking phentermine, and that is any of the ischemic heart disease, stroke, valvulopathies, also depression. And so I made sure that he didn't have any contraindications, including glaucoma, and obviously prior bariatric surgery. So in Ray's case, he was very keen to go on phentermine, which I initially started him on 15 milligrams alternate days. Given it's a sympathomimetic, I always prescribe that in the morning. And topiramate, which has the side effect of sedation, I prescribe that in the evening. And at 12 weeks, there's a stopping rule. If people don't achieve 5% weight loss by 12 weeks of the maximum dose, or are well on its way to some weight loss at 12 weeks, then you stop these medications. And he'd achieved 4 kilos weight loss, which was on its way. His blood pressure and pulse had increased a little, but weren't concerning. He'd already had some hypos, and hence I'd reduced the glyclazide dose. And he elected to stop the dapagliflozin, hoping that he was convinced that he didn't need as many medications, and this was one he had to pay for. So after the 12-week mark, we increased the phentermine to 15 milligrams daily and the topiramate to 50 milligrams at night. And he had noticed at that point that his headaches had resolved, and he hadn't had any. He'd been putting that down to tension headaches. And by 24 weeks, he reported some lessening of the of his skin complaint as well, which he was most pleased about, along with his weight loss, further weight loss of 8 kilos, down to 96 kilograms. His HbA1c, despite stopping the dapagliflozin and reducing the glyclazide dose, had improved. And again, his pulse and blood pressure were not concerning. So in summary, 35-year-old Ray had improvements in his weight and BMI. His lipids had improved, as well as his HbA1c, and he had less medications for diabetes control. I discussed at this point liraglutide, which has now become available, not funded, in New Zealand for the indication of weight management at the dose of 3 milligrams subcutaneously once daily, and that would enable him to come off the glyclazide and achieve more substantial weight loss, potentially. So liraglutide is of the same class, GLP-1 receptor agonist. It's unfunded. Its recommended retail price is $499 per pack, which contains 5 pens and lasts approximately 1 month. It's indicated as an adjunct to reduce caloric diet and increase physical activity, as are all medications for weight management, either in the setting of an obese BMI or in the overweight BMI in the presence of at least one weight-related comorbidity. And unlike phentermine topiramate, this agent is safe to use in pre-existing cardiovascular disease and has very little in the way of contraindications. So the key trial that illustrated the efficacy of liraglutide came out in the New England Journal of Medicine in 2015. And this showed that amongst people with a baseline weight of just above 100 kilograms, that compared to placebo, there was another 8% compared to placebo who achieved 2.5% weight loss. The group who received liraglutide 3 milligrams daily had 8% weight loss. And when you look at achieved weight loss, it was even better. So the other was an intention to treat analysis. The key side effect, though, of GLP-1 receptor agonists is nausea because it inhibits the gastric emptying. And whilst people at the start peaked with at around 4 weeks with nausea affecting up to a quarter of people on liraglutide, only 5% in placebo, this declined with time, and by week 8, it was reduced to 15% and had dissipated thereafter. So whilst nausea is a side effect, it does reduce over time, and you can reduce the dose when you're achieving that 3 milligram dose. So you can start low and increase slowly, a bit like metformin. Is there any questions before we go to the next case?
Good anticipation. Thank you for giving me the opportunity to ask. Just a couple of questions around the medication. If we just backtrack a little bit with regards to the topiramate and the combination that you utilised, how do you decide the dosing?
So I follow the recommended dosing for Quisimia, which we don't have. So I approximate the doses by starting with, we've only got 15 and 30 milligrams of phentermine in capsule form, so you can't actually break open the capsules and take half. So that's why I go for alternate day dosing with 15 milligrams in the morning to approximate the 7.546 with 7.525. So I start with 25 milligrams of topiramate and go up to 50 milligrams. And I found good results at 15 milligrams phentermine and 50 milligrams topiramate. Any more topiramate, I find people become more tired, and therefore I don't push it up to 100 if I'm getting good results at the 1546. So it's halfway between the established studies looking at phentermine topiramate as Quisimia.
And how does it work?
So they both work centrally on terms of weight loss, and it was when topiramate was first released for epilepsy management, they found that weight loss was a side effect that was observed, and hence it's now been trialled in the context of phentermine to amplify its effects.
In the phentermine space, now this is something that I'd experienced when I was a very junior registrar, and unfortunately it sort of coloured my perception of the medication. The individual that was wanting that particular medication was someone that was using drugs, basically drugs of abuse. Now, I'm not quite sure how much of that is really overblown and where that sits in terms of the evidence for that particular medication used in that fashion. Are you able to comment around that?
Yeah, so the addictive potential for a sympathomimetic drug like phentermine is more in relation to higher doses. And at those low doses, and I don't go above 15 milligrams, I usually stay at that dose, are very low, and I don't see that people actually do try and wean themselves off, and they will try alternate day dosing and will go back to the dose that suits them for weight loss, in my experience. I haven't actually come across anybody who's been trying to take higher doses and wanting the higher sort of doses for the symptomimetic effects of tachycardia and feeling a high from that. And yet my experience is limited. I've only got a handful of people who had been taking phentermine. My reading of the literature is that the addictive potential at those low doses is very low.
And with regards to liraglutide, would you be able to explain the mechanism of action for that particular medication? And are there any other side effects beyond nausea that we should be considering?
Yes, so liraglutide is a GLP-1 receptor agonist. So if we look at the gut, it's released from the L cells in the gut, particularly in the small intestine. So as the food is actually presented, the liraglutide, GLP-1 is released, and it acts on GLP-1 receptors, which are found in the gut as well as in the brain. And in the brain, it promotes satiety. In the gut, it slows down gastric emptying. So both of those feelings increase that sense of satiety and the fullness in the stomach, but also centrally feeling that one is less hungry than not. So the nausea comes from that kind of reduced gastric emptying. And some of the side effects that were noticed in animal experiments, which was concerning early on, was medullary thyroid cancer. But in human studies, that hasn't been found to be the case. But you may see that labeling for people who have medullary thyroid cancer, usually in the context of familial cases, should be the small print of avoiding liraglutide. There's very little evidence that it causes pancreatitis. There were some initial thoughts around gallstones, and in some cases people with obesity do have gallstones more frequently, so there may be a small increase in risk of that.
There's just a question from the forum about liraglutide. Is it used as an adjunct in heart failure?
So as an adjunct for weight loss?
I can't actually expand on that.
Okay, so the benefits of heart failure come from SGLT2 inhibitors. In terms of superiority for heart failure per se, there isn't one specifically for GLP-1 receptor agonists. They do reduce MACE, or major adverse cardiac events, so it has got some superiority data. It's certainly very safe to use in cardiovascular disease, including heart failure, for the indication of weight loss.
Just a final question or two about off-label medications. Have you ever prescribed Zyban, which is used overseas but off-label in New Zealand?
I haven't. No, it's not one I haven't.
Fair enough. And just a question / comment that Ritalin kills appetite. Has it ever been trialled in weight loss?
Yeah, I'm not aware of it being indicated for weight loss. So it may have trialled and failed, or its side effects may have outweighed its benefits. So it's not one that we use, or it's in the guidelines for obesity management.
Thank you. Probably all the questions we have for now.
Thank you. So my final case is of Moana, a 50-year-old woman a Pacific woman who'd gained a lot of weight in her late teenage years. Current weight, 130 kilograms, BMI 44.5. She's had snoring for about 10 years, but mainly complains of excessive daytime somnolence and falling asleep at the traffic lights, which was most concerning, and had a high Epworth sleepiness score. And so obstructive sleep apnea was really key, the key diagnosis for her in terms of the upper airway obstruction when she was reclining. And She went forwards for a sleep study, which showed and confirmed that she did indeed have periods of hypopnea and carbon dioxide accumulation that led to some early morning headaches, and her symptoms resolved with some CPAP training, which she used with great improvement in her symptoms. However, she was very keen to get to the bottom of the weight loss or try and minimize further weight regain. She'd had a number of obesity related complications, not only obstructive sleep apnea, but type 2 diabetes. They'd been diagnosed 3 years ago, controlled on metformin, past PCOS, and she had been unable to have children. She had been diagnosed with fatty liver on ultrasound, and she'd had heavy proteinuria even at the time of the diagnosis of type 2 diabetes, which was likely focal segmental glomerulosclerosis rather than diabetic nephropathy. She had tried to lose weight using green prescription, and over the years had 3 referrals for this. We discussed medications and bariatric surgery. She chose bariatric surgery given her financial circumstances and her multiple comorbidities and the cost effectiveness with the greater weight loss anticipated with bariatric surgery. So she went ahead with, after being referred, had seen the team and gone through the bariatric surgery process at Auckland Hospital. She had 2 weeks of Optifast preoperatively and then proceeded with the laparoscopic Roux-en-Y gastric bypass. After 3 months after the bypass, she had stopped snoring and was not needing CPAP. Her type 2 diabetes was in remission. She discontinued metformin on the day of her surgery and never needed to return to this. Her HbA1c decreased into normal levels at 38. Her liver enzymes normalized at 3 months, and her proteinuria had improved with an ACR of 260 down from 300 and something, and her EGFR was 64. Most importantly, she had improved quality of life. She was really enjoying being in smaller size clothing. Her aches and pains had resolved. She was able to see her nieces and nephews and be more active with them. And she really enjoyed the increased mobility and the physical aspects of being lighter. So just a quick summary of bariatric surgery intervention rate by DHB. We found quite striking differences in the types of surgery and the numbers by the eligible population. So in counties Manukau, predominantly all of the surgeries are done as sleeve gastrectomies, and their intervention rate is quite high, comparable with Waitemata, which actually do bypasses and sleeve in equal proportions, and they also do a biliopancreatic diversion, which is the preference of the operating surgeon there. And various other centres have a mix between bypasses and sleeve gastrectomy. And so there is some selection discrepancy by region and by surgeon. So we did a randomised controlled trial in Waitemata District Health Board and found that when we randomised patients to sleeve versus bypass, we found that the bypass patients lost more weight, but the type 2 diabetes remission was similar by both surgeries. So just to highlight, the referral criteria for funded bariatric surgery is pretty broad. Previous failed attempts at weight loss without any other details. Just being understanding and motivated for surgery, no significant heart, lung or kidney failure, no unstable psychiatric disorder. There should be referrals in the order of 2,000 to 2,000 to 1 funded places, but there isn't that demand. I understand from my bariatric surgeon colleagues, and they get a convenient number of 3 to 1 referred to operated cases. So I'd be keen to see that figure increase.
Now, Rinki, with regards to bariatric surgery and the sleeve option as well, often after these surgeries, the care for these patients will come into general practice. In terms of long-term follow-up, what are the general recommendations that you would give to us with regards to blood testing and other things that we should be looking for when caring for these patients?
Yeah, so I would continue to do the cardiovascular risk assessments at the usual intervals, so 6 monthly to annually, depending on pre-existing risk factors. And I would have the same threshold of starting medications as you would someone who was naive to the medications. So as people move into, and there is relapse of diabetes and hypertension and dyslipidemia, just as there is remission, so reintroducing those medications at the same thresholds that we have. I would still make sure that people are taking their multivitamins, for particularly for Roux-en-Y gastric bypass, and people who do present with neuropathies, making sure that that is the case and checking for B12 deficiency in that circumstance. I would continue with retinal screening, even if they did have achieved diabetes remission. There can be a little flare up in people who have abrupt declines. And I'd watch for relapse and psychological improvements. So if there were some coexisting depression earlier on, that might recur, particularly after the nadir period in 1 year. So most of the wraparound, I would say, is long term and is from year 2 onwards.
Okay, and with regards to, you alluded to the fact that actually the waiting list doesn't appear to be as long as we, I suspect, think in primary care. Is this particular for the Auckland region, or do you have any understanding of where we might lie nationally with regards to waiting lists for this particular type of surgery?
Yeah, so this is a project that I'm kind of interested in for the Auckland region, but I would be interested in other regional data around what their referral to operated ratio is. I suspect when we do the back of the envelope calculations as to how many people would be eligible, it comes to quite a frightening number. But for some reason, we don't get that frightening number being referred. So whether that is because of perceived waiting lists or actual ones, I think if the demand is there, that will make a case for growing the service. So it would be interesting to find out if other people have the experience of patients being on the waiting list for a long time or not.
Someone's just sent a comment through with regards to the Wellington region, Capital Coast, having quite a long waiting list. So it seems, at least on this very, very small sample size of one, that there's quite a lot of variability around in the country. Now, just with regards to the Optifast, when we're using it for weight loss before having surgery, Optifast, you mentioned before, something that we usually have to pay for as a patient. Under this criteria, is it funded, or is it something they have to pay for before they can have the surgery? I'm just trying to think in the equity space here.
Yeah, so I suspect that and again, this might be different in different regions, that prior to bariatric surgery, the reason for Optifast is to make laparoscopic surgery safer and shrink the liver and make it easier to pass this, do the surgery and the stapling required. So that is most likely funded, but I cannot speak for all centres. It's and it is only a 2-week commitment, and I guess it would offset the cost of food if that makes some concessions around the fact that people are replacing foods rather than having it as a supplement.
Thank you. I should let you summarise. Thank you.
Thank you. Very good questions. So in summary, people with obesity, as in any other chronic conditions, are at higher risk of complications and adverse outcomes of COVID-19 rather than actually contracting COVID-19. The lockdown period for us presented a silver lining for conducting virtual shared medical appointments for weight management using the low energy diet with initially promising results. And we have yet to see what the long-term retention is like using a mix of virtual and face-to-face appointments. In terms of individualised care for weight management and one-on-one care, this includes medically supervised very low energy diet, medications of which we have a growing list in New Zealand, particularly with the recent availability of liraglutide as a weight loss indication alone, but also we've got phentermine and and we have got referrals for public funded bariatric surgery. But ongoing follow-up is essential for this long-term condition, such as obesity. I routinely tell people that people who are losing weight are fighting their biology, and so it is going to have periods of relapse and weight regain that we need to keep revisiting and taking a long-term lens on this. Thank you very much for your attention. Yeah, any further questions would be welcome.
Thank you, Rinki. So if there are any last minute questions, please type in and say your piece. I do have one question left on my list. We went through quite a few during the course of the presentation, which was really lovely in terms of having that dynamic of presentation and questions. And that's just around keto diets. What's your opinion on them?
So ketone diets are really around extreme restriction of carbohydrates, and usually at the expense of high fat and high protein for satiation. And that's a key difference of between keto diets versus a very low calorie diet, is that the calorie content in a ketone diet is often not lower, but it's simply in the form of fat and protein. They actually do work in people who are very good at following them, like all diets. In terms of weight loss, they work. But for most people, however, keeping to under 30 grams of carbohydrate a day is simply not achievable. And what ends up happening is that people's carbohydrate intake goes up, and high carbs plus high fat is definitely not a good combination. And so I think in people who wish to do the keto diet, I will help with medication adjustment, but I'm not sure, I don't think it's for everyone. It certainly does have people who do well and people who don't, so it really has to come from very committed individuals. There's no long-term follow-up for keto diets, and they're very small studies that have been done, so further research does need to be done.
And topiramate to be taken alone?
It hasn't been shown to be as efficacious taken alone, although there has been some weight loss seen in those initial studies of migraines and epilepsy. I think the best use of topiramate comes from those Quercemia studies, and hence the combined use with phentermine.
Okay, well that's all on my question list tonight. So I'd just like to thank you once again for joining us, Rinki. It's a really informative discussion with lots of dialogue and lots of questions and answers, which is great. So thank you everyone again, and good night.